It gives me great pleasure now to introduce Steve. I think he needs no introduction. I'm sure you all know him. He's one of my nephrology colleagues at Great Ormond Street. He is going to talk to you about kidney transplantation after heart transplantation. Steve, thank you.
Thank you very much indeed, Nizam, and it's great to be back here. I always love looking at the view. If my eyes wander, it's because I'm somewhere else in London. So we're changing tack. Of course, everybody in the room understands that the kidney is the most important organ in the body. No question. You've just heard from the urologist who's trying to tell you it's the bladder. And now you've got a nephrologist who might try and tell you that maybe the heart is also a little bit important. So let's have a look. So I thought I would cover a little bit about cardiovascular disease, but also look at cardiac function and consider before and after transplantation. And we'll touch on a little bit about what's happening in America and the UK and elsewhere. So I'm going to touch on a little bit of end-stage kidney disease management. We're going to talk a little bit about, because obviously there's a lot more data, and Leslie Rees, who's speaking after me, has done a lot of work on cardiovascular disease in children, but a lot of it we gain from adults and then try and do our own thing, but look at what chronic kidney disease management and also considering both renal and cardiac transplantation. So, everybody thinks that when they're about to look at something that they've just discovered a new subject. But actually, if you go back, we can go nearly 200 years ago to 1836, when it was discovered that left ventricular hypertrophy was present in the autopsies of patients with albuminuria. So I think that's probably one of the first isolated that we realized that the heart was important. And then you can see in this timeline from the 70s and 90s, Scribner and Foley, who basically started some of the long-term work in understanding atherosclerosis, and of course arteriosclerosis came subsequently, and also that there were changes in echocardiograms in adults who were starting hemodialysis. And what we've learned is more trials and more research, but the children are not just small adults. There's different pathology, and although we learn from adult practice, there are inherent differences. So I thought I would actually share a case with you to start at the beginning. This is an 11-year-old boy. He's got end-stage kidney disease, secondary to steroid-resistant focal and segmental glomerulosclerosis, as a nephrotic syndrome presentation with hyperlipidemia, hypertension, and renal dysfunction. And he was initially managed in another centre before being referred to us. He had bilateral native nephrectomies. His kidney function prior to that had been deteriorating. He had a trial of LDL pheresis as well. He also had inflammatory bowel disease, and he had a monoclonal antibody called vedolizumab, and he started having a reaction to that, and it was stopped. By this time, his genetics for nephrotic syndrome had come back being negative, and he was running into problems with recurrent episodes of fluid overload, cardiac decompensation, and then had a severe dilated cardiomyopathy. This was the year before we saw him. And he had an intercurrent infection when his function went off. So he was started on milrinone because of his poor left ventricular function. His ejection fraction and fractional shortening were remarkably reduced. And on hemodialysis, he had intradialytic hypertension, so he was having times of hypertension and hypotension, and he ended up having an increase in his prescription for hemodialysis, and he went up to 5 sessions of 6 hours a week, so 30 hours a week. But due to the intermittent hypertension, he also had posterior reversible encephalopathy syndrome, and he required medications for having seizure activity now with topiramate, and he also had generalized tonic-clonic seizures as well. So what would you like to do to this young man? He's got poor cardiac function, he's got end-stage kidney disease, his kidneys are out. Hands up if you're going to continue with in-center hemodialysis. Who wants to commence him on peritoneal dialysis? Okay, 1 or 2. Who wants to convert him to home hemodialysis? Yep, there's a few here. Who thinks, well, we should do the kidney first and then a heart transplant? Okay, and who thinks a heart then a kidney transplant? Yep, there's a few there. And who wants to do both together? Okay, so there's a few. So I think there's a selection of different ideas. What we did, and when the referral came through to us at Gosh, we had a trial and a treatment of home hemodialysis, which we'll talk a little bit about. So we all know that renal transplantation is the best form of renal replacement therapy, but obviously you've got home and hospital, PD, hemo, and different forms of transplantation. But what we do know is that we have improved outcomes with home hemodialysis, and some of the earlier studies showing already an increase in the patient survival in adults on home hemodialysis. So this is nearly 30 years old now, coming 20 years old, I should say. And what this shows is that although we don't see children die from cardiovascular events, we have had some of our patients aged 19, 20, and early 20s die in adult practice with fluid overload and hypertension. And what this shows you is that if you have end-stage kidney disease as a child, then actually your risk of having a cardiovascular event is similar to the normal population of by age 80. So hugely increased incidence. And what we know is that the worse your renal function is, so the degree of chronic kidney disease that you have also affects your cardiovascular disease outcome. But what is it that is the interplay? And this is where it's very much debated, because chronic kidney disease is a risk factor for cardiovascular disease, but also that cardiovascular disease may be a risk factor for the progression of chronic kidney disease as well. So that's why we really feel that we need to look at both the traditional cardiovascular risk factors and the non-traditional. And these are very much stated here, so obviously there's things you can change, but as an adult, obviously you can stop smoking, you can have a better lifestyle, less sedentary, so you can have more exercise, improve your blood pressure control, improve your diet, improve your lipids, improve your salt intake as well. But there are other aspects which you can't improve, which happen over time. What about if you say, well, let's give you a kidney transplant anyway? Well, we know that cardiovascular disease is much more prevalent in both adults and children after renal transplantation. The 4C collaborative network, initially from the ESCAPE, is looking at the cardiovascular risk factors, and we're seeing changes which are ongoing in children after renal transplantation as well as before. And some people try and say, well, it's not just the traditional risk factors, there's added risk factors that we see, and part of it may be infectious complications. So for example, cytomegalovirus has been implicated in perhaps having a role, but also the immunosuppressive drugs themselves may have a role in increasing the cardiovascular risk. What I wanted to take home here was that although we do our best and we aim to have both adults and children transplanted, is that actually in a lot of the series, the biggest cause of graft failure is actually dying from another cause. So dying with a functioning graft, and actually most adults will die from a cardiovascular event as a cause of their death. So in other words, we're getting the treatment for the renal transplantation for the end-stage kidney disease, but we're not actually improving their long-term cardiovascular morbidity and mortalities. And why can that be? Well, obviously, if you are a smoker as well as being an older diabetic patient, then your risk for ischemic heart disease is hugely increased, that you can see here. What I find interesting is actually that if you're a younger non-diabetic, it didn't actually make much of a difference whether you were a smoker or not, but I think it depends on the number of cigarettes that you smoke and your cumulative amount as well. So why might be in the situation of children potentially requiring a kidney transplant and a heart transplant? Well, part of it can be because of an ischemic insult, which can be perinatal and hypoxic ischemic encephalopathy. We've had some really difficult neonates to try and manage who've got severe cardiac dysfunction. But it primarily is because of either a cardiac event, so we've seen some children have a significant arrhythmia and then have a cardiac arrest, and that's causing an ischemic insult both to the kidneys and to the heart as well. Obviously, you've got children with congenital heart disease and some of them having operations, and around the time of reparative surgery or having an arrest or having ECMO for severe dysfunction, ending up having acute tubular necrosis as a cause of acute kidney injury, and then those babies going on to have bilateral cortical necrosis. Historically, and I don't think any pediatric or adult cardiologist who was involved in transplantation would disagree that there were a huge number of patients who had cyclosporine-induced nephrotoxicity because the management of immunosuppression after a heart transplant, the feeling was this is your only transplant that you're going to have. We need to stop you having an acute rejection. And there were very, very high levels which were used historically. And that caused the nephrotoxicity from the calcineurin inhibition. But we do see secondary conditions, and they may be microangiopathy, hemolytic uremic syndrome, post-transplantation is seen, and we've also seen some children with a C3 glomerulopathy-like illness, so a membranoproliferative glomerulonephritis, post-cardiac transplantation as well. So what can we do? Well, what I was trying to get on with the home hemodialysis is that you might be able to make some of these changes. But there are a lot of work going on to looking at reverse modeling and improvement in cardiac function after transplantation. So this was a group who looked at baseline systolic dysfunction, and it was a group of patients, and as you can see, there was over 1,000 who had pre-transplant echocardiograms. There wasn't much of a difference between the two. And then they looked at what their outcome measures were by looking at both the morphology of the cardiac, so what the dimensions were, but also the overall cardiac function. And what they showed is that there was an impact of impaired pre-transplant left ventricular and diastolic function on the post-transplant survival that you can see here. So if you compared the groups that had normal baseline left ventricular morphology and function, their survival was actually significantly improved. However, if you were able to improve that function post-transplantation, then some of these patients actually, their overall cardiovascular mortality and morbidity hugely improved. Now, Professor Rees is sitting in the front row, so I couldn't but state that one of the obvious things is actually, and I mentioned it earlier, was your management of anemia, because actually improving your hemoglobin, which of course happens post-transplantation, generally, although maybe reduced by using immunosuppression such as mycophenolate mofetil, that even by just improving your anemia management actually will improve your left ventricular ejection fraction as well. This was a group in Egypt who looked at 150 patients. There was 30 adults and 30 children who had renal transplant recipients, as well as those on hemodialysis in normal population. And what they showed is basically in adults, they had an improvement in the left ventricular end diastolic volume and improvement in ejection fraction and fraction shortening, and that was seen as well in their pediatric population as well. So the changes weren't as significant in the children as they were in the adults, but there was definitely an improvement as well. So one thing to consider, of course, is you could do a combined kidney and heart transplant if you really have a patient who's in intensive care. Now, that's not something we would all jump at with joy, because of course, what do we want after a transplant, for a kidney transplant? We want to give fluids. What do they restrict when you do a heart transplant? It's fluids. So there is a real debate about what is the best modality. And of course, part of the reason is that you're wanting to do transplants. So this was data which was published in 13 adults from a single donor. And what I wanted to show you that if you look at this, there was about a third of the patients survived the whole time, and that is up to a median of 15 months it's supposed to be. So if we look at 30 consecutive adults who had a combined heart and lung transplant, and we compare it to 440 just adults who have a cardiac transplant, you can see that immunologically they do very well with reduced rejection episodes. So what about in the UK? Well, there's been 8 pediatric transplants over the last 10 years. We haven't had any case at Gosh, but there's one case of a simultaneous heart and kidney transplant in the UK. In the United States, there's been 38 cases reported by UNOS over 30 years, and these are a single center from UCLA, where they actually, if you look at what the ejection fraction was, some of them you would actually question whether they need a heart transplant. And then if you look at their estimated GFR, you would question whether some of them actually needed a kidney transplant, because their take was that they would do a combined if the eGFR was less than 50 mils per minute per 1.73 meters squared. So to end, what are you going to consider to do to your patient? Well, we put him on home hemodialysis. He had a trial of nocturnal. He went forward and had a living donor transplant, but unfortunately had a recurrence of his nephrotic syndrome. He ended up having SVC obstruction, a real difficult case, both psychologically and medical. His kidney function and his fractional shortening deteriorated, and he started becoming hyperkalemic. And we ended up putting him on peritoneal dialysis with improved heart function, but he's going to require another kidney transplant if we know what the treatment is for recurrence of FSGS. So I'd just like to thank everybody in the team, not just the nephrologists, but the surgeons, the interventional radiologists, but the multidisciplinary team with anaesthetists, cardiologists, gastroenterologists, the doctors, and the whole nursing and MDT team. Thank you very much.
Steve, thank you. And thanks for sticking to time. I think we've got time for just a couple of questions.
Or can you think about the other way around it? When you have a heart failure, when do you determine to do a kidney?
So when to do a kidney transplant?
Kind of go to the same place, but looking from a different point of view.
Yeah, so what I guess my take home is before we would do the kidney, you would want to try and improve the heart function as much as you can. So obviously medical treatment. Professor Rees will tell you that the most important thing with hypertension is fluid and salt. And we constantly find that when you reduce that, you actually will improve the fluid overload and actually the long-term outcome from the heart point of view, and that heart function will improve, thereby making it easier to do a kidney transplant without hopefully needing to do combined.
Okay, thanks, Steve.
Thank you.